Today I'm going to talk about chemo protocols and the nutrition. We'll understand why the nutrition is most important in treatment of malignancies. So now this is a typical how an induction phase looks like. So what are the drugs here we are using? So this child, after the completion of initial first days, you start with steroid therapy. Usually it's prednisolone for first 7 days. And then during the first 7 days, at least for initial 3 to 5 days, you have to look for the tumor lysis if there is any. And accordingly manage the potassium, phosphorus, calcium. As a medical therapy, we do not supplement any calcium for them. Very rarely it happens that some children come with a little lower potassium, but in that case also we do not supplement any potassium because slowly the potassium goes up only because of the tumor lysis. So no added potassium. When we are giving IV fluids also, there has to be no added potassium in that, and no calcium unless they have a tetany. Okay, if they are symptomatic, then we supplement with the calcium. So after the completion of the first 7 days, we go on to the induction phase. The induction phase typically lasts for about 33 days. And on the day 33, here we do a bone marrow test to assess the effect of the chemotherapy. So it lasts for around 33 days. It's an intensive regimen. So the drugs used include prednisolone, vincristine, daunorubicin and asparaginase. Okay, so I'll tell you about each drug and what are the nutritional consideration for each of the drugs. So what are the considerations or what are the complications which happen with steroids is steroid can cause hypertension, it can cause hyperglycemia. Okay, and with the steroid what happens is children feel very hungry. We want to eat all the time. Okay, many of the parents will come and tell that they wake them up, the children wake them up at night and want to eat. Now, as a nutritionist, you will have to counsel them as in what to give them when they are hungry and they have altered taste and they want to eat things like chips and all. Chips, biscuits and all. And what happens is once they get the habit of eating this during the cancer therapy, this habit continues when they are completed their treatment also. And when we see them after the completion of their treatment, they tend to have metabolic syndromes. So we have to counsel the parents very carefully as in what to eat and what not to give to them. Okay. So anything which is very rich in sugars or very rich lot of salts in it should definitely be avoided because many children with steroids also are hypertensive and they require antihypertensives as well. The next drug is vincristine, and vincristine what it causes is it may cause constipation. So what you need to do is give fiber rich diet. Okay, and I'm sure you all know what are the fiber-rich diet, which includes oats, bananas. In oncology, we do not use the probiotics which are available in market. So, but we advocate them to use the natural probiotics like curds and all. The third drug is daunorubicin, and the complications with daunorubicin is it causes mucositis. It can cause severe neutropenia. So if there is mucositis, the child may not be able to eat very well because of the soreness in the mouth. So ask them to avoid spicy food. Ask them to have good oral hygiene, because with the good oral hygiene, you can prevent the occurrence of mucositis. Glutamine sachet, we have been using at Wadia. There are we did actually see the literature. There were a few reports which have advocated that glutamine may or may not be used, but finally we found that there is good evidence that it can be used. So glutamine sachet is good to use. And some of them, because of the severe mucositis, may require parenteral nutrition, either a partial or a total parenteral nutrition. Then the fourth drug which is used during the induction is asparaginase. Asparaginase, the main side effect is pancreatitis. So again, because of the pancreatitis, they may have high sugar levels. So you need to check the sugar levels regularly, and anything which is rich in sugar should be avoided. So this is how the second cycle. So after you have completed the first cycle, the child undergoes a bone marrow aspirate to see how the status of the disease is, and next then the child goes on for the early intensification. We make a decision on putting an augmented early intensification or normal early intensification based on the bone marrow aspirate report and based on the cytogenetic report of the child. In the early intensification cycle, the child is on 6-MP, cytarabine, cyclophosphamide, and receives intrathecal methotrexate. Yeah. So early intensification typically lasts for total duration of 64 days. It is actually, thankfully, it's little less intensive as compared to the induction phase. So you see less complications here as compared to the first cycle. And as I mentioned, the drugs here include 6-MP, cytarabine, and cyclophosphamide. So with 6-MP, many children have loss of appetite. So especially when they are in the maintenance, many of them come with the complaints of poor appetite. We advise them is to have food. Maybe even if they are having lesser food, it should be calorie appropriate for the child, calorie dense maybe. It should be easily palatable and small quantity at a time. Many of the children are not able to eat a lot at one go. So let them eat at frequent intervals and maybe smaller quantities. Okay. Then the second drug is cytarabine. Cytarabine again causes a lot of neutropenia. So again, with neutropenia, we have already learned what we need to do is give the neutropenic diet, and if it's very severe neutropenia, child has got any infection, has admitted with enterocolitis or something, we may have to supplement with either partial parenteral nutrition or total parenteral nutrition. And then comes the cyclophosphamide. So cyclophosphamide is excreted through kidney, okay, and so that time whenever the child is receiving cyclophosphamide, we have to instruct them to maintain a good hydration. From medical point of view, what we normally do is, for whenever they are on cyclophosphamide, we have to ensure that they pass urine also very well, because the drug gets concentrated in the bladder. Okay, so we ensure that the drug is given during the daytime and not during the night time. So this is told to the nurses as well, because if we give it during the evening hours, the child may not get up at night and may not pass urine. So it can lead to hemorrhagic cystitis. That's a known complication of cyclophosphamide. After this comes the protocol M. It's the interim maintenance protocol. Okay. So interim maintenance protocol, what are the medications which we use? It's only two medications here. We give 6-MP and methotrexate. It's a high dose methotrexate. For TALL, it's very high dose, like it's up to 5 gram per meter square, and for BALL, it's usually 2 gram per meter square. Methotrexate might differ for different patients in the different protocols. Okay, so BFM, it gives 2 gram for BALL, while it gives 5 gram for the TALL. I think for icicle it is 3 gram. So it will be a little bit different at different places. Majority of the Indian centers, icicle protocol is being used. That 6-MP can cause loss of appetite. So with mucositis, we have already discussed what needs to be done. So prevention is very important. So even before they start their third cycle, we advise the parents about the oral care. And these are the grades of different mucositis, grade 1, 2, 3, 4. So if grade 1 and 2 are usually manageable by on OPD basis itself, for grade 3 mucositis, you require to admit them and give them hydration for the, because they are not able to eat, drink well. So for their nutritional requirement, you require to admit them and give partial parenteral or total parenteral nutrition. So good oral hygiene by mouthwash, brushing the teeth twice a day, and you advise them to use soft brush because some of them may have thrombocytopenia and may lead to bleeding if they are using a hard brush. It's very important to involve a dentist as well. Then as I mentioned earlier, small meals, calorie dense, and any food which is easy to chew should be asked if there is mucositis. Liquid based diet, which could be like milkshakes or pureed food. Any hot foods might cause irritation, so that may be avoided. You could use a straw to drink. Oily and greasy food has to be avoided. And it's important that the constipation is avoided by having fiber-rich diet and dietary supplements, good hydration and water intake. Enteral and parenteral nutrition as required if in grade 3 or 4 or if there is a NEC. After this is the reinduction phase. Again, this is a very intensive phase and it is very similar to induction phase. Okay. And what are the drugs we are using here? We are using dexamethasone, again a steroid, and it's more potent than prednisolone. Then 6 Tg has not been available for long, so most of the time instead of 6 Tg we have been using 6-MP. Again, cytarabine, that comes in the second phase, both 6-MP, cytarabine in the second phase of it. Doxorubicin, cyclophosphamide, asparaginase and intrathecal. So more or less whatever we have used so far, this is again the combination of the same. And because we are using almost all of them, it's maximum toxicity we see in this phase. Okay. And here then again in the phase 2 it's mainly the cytarabine and 6-MP and cyclophosphamide. So the total duration of this protocol is for 50 days. Dexamethasone, vincristine, doxorubicin, cyclophosphamide, cytarabine and 6-MP we are using in these phase. So dexamethasone, similar to the prednisolone, the side effect includes hyperglycemia, hypertension and behavioral changes that we see much more common with dexamethasone than prednisolone. Okay. So one thing what we advise them, especially if they are having the dexamethasone late at night, they are not able to sleep. So we tell them to have it a little earlier on, like before 6 o'clock. Okay. All steroid medicines, they cause lot of gastritis. So we have to tell them to eat it after food. Okay. So like that, I think you all should also emphasize if any of the parent is coming and telling you that the child is having lot of gastritis, see if they are on steroid medicines and are they taking it appropriately. If they are taking it on an empty stomach, the chances of gastritis is high. We already talked about vincristine. So vincristine causes constipation and it causes, so for that fiber-rich diet is advised. And again, as we mentioned earlier, natural probiotics and oats and bananas and all. Doxorubicin is like similar to donorubicin in the first phase. Again, it causes mucositis and severe neutropenia, and we have already learned what needs to be done during that one. Okay, so good oral hygiene, as and when required, PPN or TPN. And cyclophosphamide also we discussed that it can cause hemorrhagic cystitis, and we need to have good oral or IV hydration after cyclophosphamide, especially if the dose is more than 1 gram per meter square. If it's around 500 milligram per meter square, you can have normal oral hydration is okay, but if it's more than 1 gram per meter square, definitely IV hydration is required. Now comes the maintenance, which lasts for 2 years. During the maintenance, only 2 drugs are used, 6-MP and methotrexate in BFM protocol. Some other protocol, they continue to have small blocks of vincristine and dexamethasone. So 5 days of dexamethasone along with a one injection of vincristine, which happens every 6 weeks or 3 monthly. Okay, so in BFM protocol, it's only 6-MP and oral methotrexate, and there are 4 ITs or 6 ITs based on the child's cytogenetic status, and some of them may require radiation. During the maintenance phase, we see a lot of patients coming in with the complaints of poor appetite, and that's mainly because of the 6-MP. So again, as I discussed earlier on, small frequent quantity meal may help them. Okay, and methotrexate can, even though it's a oral methotrexate, it's not a high dose methotrexate. Some of the children may come with mucositis, and we continue to advise them to have a good oral hygiene. So this is a typical protocol of maintenance therapy. Now, some of the children, as I mentioned, may come with obesity. Okay, it's not too common in India, and especially in Vadia children, where many patients who are coming from low socioeconomic status, we don't get too many children with obesity. But if you get, then you have to first see what could be the causes, what could be the consequences, and what interventions you need to take. So what could be the causes? It could be like, poor dietary habits before they started the treatment. So like, they have been eating a lot of junk food. So that could be one of the cause. Reduced physical activity. The reduced physical activity now could be just because now many children are too much into like sitting and watching mobile. So it could be because of that, or it could be because of the child's condition. So like maybe if the child has got say some bone tumor or something where he's not mobile for some time and just sitting at home. So that also could be one of the reasons. It also could be because of like, CNS involvement of the disease. So sometimes the leukemia, CNS leukemia, there is disturbance in the hypothalamic axis. So some of them come with a very severe weight loss, and some of them may come with a weight gain. So what happens? What are the problems you face when a child comes with obesity? There is increased treatment-related mortality. It has been found that the survival rate in them is low, and lots of many other comorbidities and the risk of second cancers due to obesity in survivorship and adulthood. What intervention you need to take? So you need to have interdisciplinary family-centered programs for behavioral, dietary and physical activity change. You may have required to do some pharmacological intervention, surgery for hypothalamic obesity. They can also have tumor-related obesity, okay? Or like treatment, during treatment, as I told you, we are using a lot of steroid. When they are on steroids, they are hungry all the time. And at that time, if they start having wrong kind of food, then it can lead to obesity. And especially like now, it's really good that the childhood cancer survival is very good. So not only we have to support them during the therapy, even after they have completed, we have to ensure that they live a healthy life. Now there are other tumors like osteosarcoma and neuroblastoma. So what are the consideration or what are the protocols used in osteosarcoma? So in osteosarcoma, the drugs which are used are daunorubicin and the adriamycin and methotrexate. So here the methotrexate dose is very high. It's much more higher than the ALL protocol. It's in fact, it's around 12 gram per meter square. Okay, so that can lead to a lot of mucositis and and up to grade 3-4 mucositis. So these you should remember. So if any child is being treated for osteosarcoma, the importance of oral hygiene has to be explained, and what diet to start, and what diet even to prevent, and if they get a mucositis, how they can what kind of diet they should be taking so that they have minimal discomfort. Neuroblastoma, in the beginning we discussed, it's an abdominal tumor. So the treatment for neuroblastomas usually lasts for 6 months. It will be different for different age group. For infants, it's usually a very good prognosis. Only problems we face with infants is the intake or poor intake because of the abdominal distension. Older children usually don't do that well. Usually their biology is not that good. but their treatment, many of them required autologous transplant also during their treatment. So for them also it's very important to keep their nutrition built up. But the good part is their treatment is not that toxic. Usually they don't get that much neutropenia. They don't get admitted too much. The emetogenic potentiality of the drugs is also not that bad. So we are able to maintain the nutrition of those children. But why we face problem, or why I'm saying that their outcome is not good, because the disease usually tend to relapse. So that's why. Otherwise the infant neuroblastoma prognosis is very good. Okay. If there is head and neck tumor, so if there is a swelling here, the child may not be able to eat very well, so you may have to give RT feeds to that child. What are the pillars of dietary nutrition? Very, very important that we counsel the family. In fact, if the children and the parents, they all need to be told. And in fact, we always take the help of our counselors as well whenever we are doing a dietary advice. And there are certain children, as I said, because they have to be admitted for so long, they don't feel like eating. So sometimes play therapy works. So if you maybe as doctors or maybe as nutritionists, you may not have that much time to stay with the child and ensure to eat. The counselor's help is really good. We have many counselors who will come, sit with them, play with them and talk to them. And when that is done, we have seen that the diet intake improves. Okay, so do take, if you have that facility in your hospital, then do involve them during the counseling also. Or if whenever the child is admitted, do take their help. It really helps. Regular assessment during the entire course of therapy. As a nutritionist, you all know what all to monitor when the child is on chemotherapy. Neutropenic diet is important to advise, and you have already learned what is a neutropenic diet. As in when required, dietary supplements to be given. As in when required, or you may have to give RT feeds. So discuss with your doctors. There is a chance of having a mucositis, so why not do it preemptively rather than wait for the mucositis to happen and then struggle. Because that time it's difficult to put in. The doctors will not allow, and then you may have a tussle. So even before this one, you consult or speak to the doctor and take a call. Okay. And as and when require parenteral nutrition, in oncology we mainly give parenteral nutrition with the NEC patients or those who are in sepsis, or we think that the child may not be able to eat well for next few days. The indications for parenteral nutrition may be higher when there is a child in bone marrow transplant unit. So underlying malignancy and increased physiological demands with effects of multimodal therapy lead to high risk of developing short and long-term nutritional deficiencies that needs to be considered. Nutritional status affects disease outcomes as they can modify the tumor microenvironment and potentially alter chemotherapy pharmacokinetics. And regular assessment and dietary intervention is key to manage the nutritional deficits. Both the undernutrition and overnutrition outcome may not be that good, so that needs to be taken care of. And awareness about good nutrition among parents and patients is of utmost importance. Thank you. I'm really glad you all were so attentive and good listeners. Thank you.